YouTube. So with all your permission, can you do that?
Yeah.
Okay, so yeah, just give me a minute. Okay, we are live now on YouTube and the recording is also started. So you can start from your end now.
Welcome, Parenchyma, sir.
Good evening and welcome all the esteemed faculties, students and delegate on behalf of Academy of Paediatrics, Gujarat. This is a presidential action plan, Academy of Paediatrics e-Gurukul PG Clinic, which is second season started just a month back. Today with us we have our project in charge, Dr. Yogesh Parikh sir. Just a minute. Can someone call Rakesh sir? He want to join. I think he won't able to. With our project coordinator, project convener, Dr. Baldev Prajapati sir, and project coordinator, Dr. Nehal. So with my co-host, Dr. Nehal, I will welcome you all on behalf of e-Gurukul AOPG Gujarat. So I request Yogesh sir to give their blessings. Yogesh sir, yeah.
By Prajapati sir.
Yeah, Baldev sir, please. Dr. Baldev sir is a veteran pediatrician and past president of Academy of Paediatrics Gujarat. So I welcome you. Welcome Dr. Baldev sir. Is a convener of Project e-Gurukul PG Clinic. So request Dr. Baldev sir to give their blessings. Dr. Baldev sir, mic is with you.
Good evening, friends. I think already it is going on since last 2 weeks, but unfortunately I could not join due to some reasons. This time I am there fully for 2 hours, and I'm sure that this presenter must have come with a good preparation. I think if suppose no formality straight away, should I ask the student to start the history part? Yogesh bhai?
Yes, sir.
Sir, first we'll introduce the mentors expert and then we'll start.
Yes. I think that part you can do it, please.
Yeah, thank you, sir.
Kirit, you are not audible. You are not audible.
Not audible, Kirit bhai. Not audible.
Pediatric respiratory diploma in pediatric respiratory medicine and diploma in pediatric sleep clinic and additional professor of pediatric at AIIMS Jodhpur, Rajasthan. And another expert is Dr. Amitosh Singh, who is an pediatric cardiologist. He's trained at Kochi, Kerala, and consultant cardiologist at Aster Medicity, Kochi, Kerala, past cardiologist, and right now practicing consultant pediatric and fetal cardiologist at Mohali, ACE Heart and Vascular Institute. So welcome our experts for today's session. And now I request our presenter, Dr. Mohima Chaudhary, to start with the presentation of his case.
Kirit bhai, Rakesh bhai is there.
Yeah, sorry, actually. I cannot see. Oh,
yes, he's seen.
Welcome, Dr. Rakesh sir, President AOP Gujarat. So I request Rakesh sir to give their words. Rakesh sir.
So not very good evening to all, and without wasting time, I welcome you all here, all the dignitaries and all the experts here on this platform. It's a very prestigious project, dream project of Dr. Yogesh bhai started yesterday and got now momentum. We are really pleased. We have Dr. Baldev bhai Prajapati as our convener. He's a real teacher of all teachers, and we are all PG students, and we all are very fortunate to have him here today. I'm sure today's session is also going to be a great success and great learning experience for all of us. So over to Dr. Kirit. Thank you.
Thank you, Rakesh sir. Yogesh sir.
Hey, let us start. First of all, congratulations to Dr. Udit Chaudhary to present the case today's PG clinic program. And uh, as usual, our mentors, Dr. Baldev Prajapati sir is always with us. And thank you, Dr. Kirit Bhai and Dr. Rakesh Bhai to continue this e-Gurukul program. And we also thanks Dr. Nehal Patel Madam as a project coordinator and Dr. Prashant Karia to conduct this session. So let us start the session.
So I request Dr. Mahima Chaudhary to present his case for today's case discussion. It is on cyanosis.
I think Dr. Udit, before you start presentation, am I right? She is presenter.
Her name is
Yes, yes.
Udit or Mahima?
Sorry. What is your name so that I can pronounce it properly?
Dr. Mahima Chaudhary.
Dr. Mahima Chaudhary.
Your
Okay, somehow
name
I
is
think
Dr.
the name is seems something else.
Yeah.
Anyway, I think just for the information to all the participants, students, as well as the faculties, that as a flow of the discussion, first the presenter will start with the history part. And I think from the history we'll start the discussion. At the end of history, we should be in the position to at least give some provisional thought process that what is our hypothesis regarding the case. And next, again, further we'll go for the examination and then this provisional clinical diagnosis. Meanwhile, in the discussion, I hope that some of the students should be there on the screen and even on the attendees link. They can participate by putting their questions, queries on the chat box. We'll incorporate and our experts are there to help us. We'll start with the, I will say, general pediatrics, but keeping in mind particularly the examination of the MD and the DNB students. And meanwhile, the experts will add to our knowledge, particularly some new development, advancement in the field of some of the specialty. And I think in that way, all of us will try to learn from each other. And so that students should be at the maximum benefits in the exam. And of course, all of us are learning this subject. I hope that this will be the good flow so that we can have the meaningful utilization of the time of the 2 hours. Is it okay?
Yes, sir. This year we have a 2 platforms. One platform is a Clarinet platform, and the second one is the YouTube. So
Right.
we have only this Clarinet platform. We are seeing like faculty and presenter only, and officer. But viewers on the YouTube link, so they are asking question on the YouTube. So Dr.
That's
Nehal
fine.
or Dr. Kirit will take from the YouTube.
Yeah. Yeah, I request both of them that in between you can put some questions. Suppose somebody has asked, and we'll incorporate in the discussion. We'll take the help of the experts even for very sharpening of this, particularly the field of knowledge. So I think we will be able to utilize these 2 hours in a best manner. With that, I request Dr. Mahima Chaudhary to share her PPT and start with the history part.
Good evening, everyone. I am Dr. Mahima Chaudhary, second year DNB resident from Kashiben Govardhan Das Patel Children's Hospital, and my mentor is Dr. Urbinder Kaur, pediatric hemato-oncologist. The informant was a mother with a 5-year-old male child.
Dr. Mahima, your PPT is not seen on the screen.
Okay, sir.
Can you just start to share?
Okay, sir.
Dr. Mahima, you have already shared the PPT previously. So,
Yes.
Yeah, you have to open the PPT in the on the desktop first.
I think before some time, someone's PPT is already on present. Who was that screen?
Sir, My PPT is already there on the screen.
Then you have to
But
share.
you have to share it.
Yeah, the green button is there, the share screen. See the bottom line.
At the bottom.
Slideshow.
Yeah. Yeah. Now make it as a slideshow. Yes. The slideshow.
Is it visible?
Yeah, it is visible, but make it as a slideshow, not on the only the current slide. Whole your PPT should be in the one line.
Sir, it is in the slideshow mode.
Okay, now go to the second slide. Yeah, okay. Now start, please.
The informant was a mother with a 5-year-old male child, Hindu by religion, residing at Alkapuri, Vadodara, presented with chief complaints of breathlessness on exertion since 1 year, EC fatigability and decreased playing since 6 to 7 months, and bluish discoloration of lips and nails since 15 days. Patient was apparently all right 1 year back. Then parents noticed that child was becoming breathless on running. Gradually, breathlessness had progressed and he was getting breathless on walking upstairs and long distances. He used to stop after walking up 5 to 6 steps or around 100-meter distance. It was aggravated by physical activity and relieved on rest and lying down position. No seasonal variation was seen. Since last 6 to 7 months, he was getting tired easily and had decreased playing activity. Since last 1 month, he was unable to do routine activities efficiently. He also had frequent bouts of cough since last 6 to 7 months. 4 episodes were present in 6 months, each lasting for 5 to 6 days. It was dry, intermittent, non-spasmodic in nature, no diurnal or positional variation, not associated with chest pain or hemoptysis, no aggravating factors observed. For the above complaints, patient was given OPD-based symptomatic treatment multiple times with partial relief of symptoms. 15 days prior to admission, child had acute febrile illness which lasted for 3 days associated with cough, cold, which got partially relieved by medication. After this, mother had noticed bluish discoloration of lips and nails. It was persistent with no aggravating or relieving factor. It was not associated with distress at rest. They took consultation nearby where sonography of heart was done, which was normal. There is no history of any cyanotic spell, suck-rest suck cycle, excessive sweating, orthopnea, chest pain, edema of fit, oliguria or any other urinary complaint, or exposure to any accidental drug or toxin, convulsion, unconsciousness, allergy, or need of frequent nebulization. There is no past history of any admission. In antenatal history, the mother had regular antenatal visits and ultrasonography was normal. She received iron, folic acid and tetanus toxoid. No history of drug intake, radiation exposure, diabetes, hypertension, thyroid disorder, fever, rash or leaking per vagina. The patient was born to a 30-year-old female child, third by birth order, born out of non-consanguineous marriage, full-term normal vaginal delivery, cried immediately after birth, 2.5 kg birth weight with no NICU stay. He achieved milestones appropriate for age. Child was on exclusive breastfeed till 6 months of age and complementary feeding was started after 6 months and child is on home-based diet since 1 year of age. Currently, his calorie intake is 1200 kilocalorie with expected of 1400 and deficit of 14% and 16 gram intake of protein with expected of 18 gram and 12% deficit. He has been immunized till 5 years of age as per national immunization schedule with no records available. He has 3 siblings who are apparently healthy. No family history of any chronic lung disease, asthma, or congenital heart disease. No history of similar complaints in the siblings. Socioeconomic status is upper middle class. So should I continue?
No, Dr. Meva, unfortunately, I lost the connection for some time. I lost the history part. Can you just run the slides for the sake of me? I will go through it. Sorry.
Okay, sir. So
Just
from
you can.
where I have to continue?
No, I think only history part. Can you just start the first slide because I lost the connection immediately as you started.
Okay.
First slide. Yes, it's a 5 years old male child.
Hindu
and
by
breathlessness.
religion.
Yeah.
Hindu by religion, residing at Alkaburi, Vadodara, presented with
Okay.
chief complaints.
I think you may not repeat it because it will be the repetition to others. Just I will note it that 5 years old child, breathlessness on exertion, particularly since 1 year, and easy fatigability and decreased playing since 6 to 7 months, and bluish discoloration of lips and nails since 15 days. I think we can start from here. Forget regarding this rest of the part. Then we'll go for the details of the information. That suppose 5 years old child enters your room, you are sitting in the OPD with even take the only first symptom that breathlessness on exertions is 1 year. What things will come to your mind? Or what other questions you will ask to the mother or to the child is able to answer so that you can gather more details of the information. Breathlessness on exertion since 1 year. What other questions you will ask? And how will you interpret? How will you analyze?
Frequent episodes of frequent episodes of cough and cold. Then breathlessness on exertion, has it progressed or is it similar?
Right?
And is it associated with any other symptom like easy fatigability? Then does the child require frequent admissions for it?
Okay.
And is it associated with any other features like fever, cough, cold, hemoptysis, or edema?
I think, Dr. Mahima, what I will just suggest you that try to focus on the main symptom, breathlessness or exertion, which is since 1 year. It's a very long time. So probably if you go in more details, that will provide lot many information which will help you for further analysis. Suppose exactly 1 year, that means this problem started at the age of 4 years.
Yes, sir.
Right? What question you will ask to the mother regarding the onset? You know, onset of the symptom is very important.
Yes, sir.
So what questions would you like to ask the mother?
How did breathlessness started and how did it progress? Means initially the child was had breathlessness on walking on long distances or any other activity.
Just what I will suggest you, most of the time seeing these are the chronic disorders, what happens? They are focusing since 1 year. Parents will be also focusing since 1 year. But you know when the symptoms of the problem started. But you know certain hidden or subtle problems may be there that you should ask. And that if you ask that was it child totally normal before 1 year?
Yes, sir.
Then they will complain or they will mention which they are not considered significant. Then they will say, no, at least he was getting tired. He was not interested in playing. Or even he is avoiding some exercise, something that gives that the problem was even before that, before this exertion, breathlessness or exertion. And you know, most of the times in these type of chronic illnesses, some subtle problems are there that you will have to dig it out to go in the details. And that gives the idea that probably the illness was before that, right? After that breathlessness, you can go in the details on exertion, exactly what you started, particularly how it started. What was the progress? Very rightly you say. Or even, gradually child be having the breathlessness. Can you give me some gradings of this breathlessness or dyspnea, what we say?
NYHA grading and modified Ross grading.
Okay. What is it? What is it?
In modified Ross scale, in grade 0, the child is not breathless on exertion. In
Right.
grade 1, the child is breathlessness on going upstairs. In grade 2, the child is breathless on walking for long distances. In grade 3, he is breathless at 100-meter distance. And in grade 4, he is breathless even at rest.
Right. I think very rightly you mentioned, it was simply if we try to understand how they complain. This is our grading. But usually, breathlessness and exertion, some adult person or older child will complain in this way. That breathlessness on unaccustomed exercise. Suppose I'm daily walking since, I will say 3 kilometers since many years. I will simply say that I'm quite comfortable. This is accustomed exercise for me. But if I walk for 4 kilometers, then I become the breathless. And that's why how the person will complain that even with the 3 kilometers distance, I become the breathless. And that is the accustomed exercise for the person. So what is the accustomed and not in the unaccustomed exercise? Later on, as you say, even without the exercise or with this routine activity or even at rest, that gradually give us the idea that gradually the disease is becoming the progressive, making the person breathless even with the short distances also or even at rest. And that gives the severity of the progress of the disease. Right. So that is our idea. And I think that you should take for the 1 year. Because in the 1 year, it will not be the static. There must be some changes. So that you may take in the origin duration progress. Second, easy fatigability and decreased playing. How will you take it? How will you interpret it?
The child is not interested in the activities which he was interested in previously. Means he was very playful previously, but now he is not that much playful. And
simply, Mahima, I will say it is the anemia. Suppose if I focus only the second complaint, easy fatigability, decreased playing, I think that is very common with the anemia. That you become the fatigue, or even your attention span decreases, concentration decreases, activity decreases, right? Or even some restriction of the lung or the cardiac functions. That can also make the person fatigue and decrease playing. But with the reference to breathlessness and easy fatigability and decreased playing, I may take even still anemia. But in the anemia since 1 year, I think that is not convincing. Either it will progress, which will require some, I would say, advice of the medical person, or probably with some medicine, suppose they have taken orally, it should be managed. So probably it is beyond this simple nutritional anemia. And now if you add the third complaint, bluish discoloration of lips and nails, so it becomes now very clear. It's not anemia. It's not nutritional problem. It is something else. And something else you can at least have the idea that maybe the cardiac, maybe the respiratory. Right? How will you take it? Cardiac or respiratory, which one is favoring? I think, always try to, maybe what I will suggest you, always try to think from the first symptom, add the second symptom. And it is like the story of the elephant. If you put the 5 symptoms together, that gives you some image that this is likely this problem. So with these 3 symptoms now, what will be your thought process?
Sir, in respiratory, there is more of tachypnea. But
Right.
here, the patient does not have complaint of tachypnea at rest.
Right.
As the complaints are of 1 year. In cardiac, tachypnea is not that much visible.
Okay.
Other than that, respiratory.
In other way, let me tell you, I'm sure that,
Excessive sweating
okay,
at
you,
night.
maybe if I give you some hints or idea, what is the basic cause of cyanosis in cardiac condition?
Basic cause.
What
It is due to the.
basic pathophysiology, what I mean to say.
It is due to the shunting of blood.
It is reduced hemoglobin.
Reduced hemoglobin.
Right?
Yes.
And
yes.
reduced hemoglobin is due to the mixing up.
Mixing of blood.
And therefore initially that would be the small mixing up. As the mixing up, and therefore initially that would be the small mixing up. As the mixing up increases, degree of cyanosis will increases. But
Yes.
but what I mean to say, the cardiac condition, the first complaint or the chief complaint is usually the cyanosis.
Okay.
The bluish discoloration may be the first complaint. And with this degree of cyanosis increasing, other problems will increase in the form of the breathlessness, in the form of even span, in the form of even the not growing, in form of even some other thing. But it is the basic disease process is this much. Here it is reverse. First breathlessness, fatigability, and now cyanosis is just 15 days. That means it has developed late, even after 1 year, probably beyond 1 year. Then what does it indicate?
It can be due any respiratory or cardiac.
Okay. Suppose if you want to explain on respiratory basis, how will you try to explain?
On respiratory basis, the patient will present with breathlessness. On giving the oxygen of 100% for 10 minutes.
No, only from the complaints. Only
Okay,
from
only
these
from the
symptoms, yes.
Okay. Patient will complain of cough and cold, frequent cough and cold. Then,
Depends what is the pathology, what is the disease. In all the diseases may not be the fever and cough.
yes.
In other way, let me give you the idea. Then we'll learn from our, I would say, specialist persons, pulmonologists and cardiologists. But what happens? There are 4 components in respiratory system. One is the lung parenchyma. Second is the airway. Third is the pleura. And fourth is the interstitium. Now, with the involvement of each component, there will be the different manifestations. Disease may be the anything, right? I hope that you will be able to understand what I'm suggesting.
Yes, sir.
I think commonly airway disease, how they present, and keep in mind the airway disease as the bronchial asthma. Bronchial asthma is the airway disease.
Yes, sir.
So what are the common presentations of airway disorders?
Breathlessness on exertion.
Okay.
Cough.
Even asthma not necessarily exertion, even at the rest person become the breathless.
Yes, sir.
Because there is a narrowing of the airway.
Any trigger agent can be there.
Yeah, there is the inflammation. Yes. There is the constriction of the smooth muscles. And therefore there is the narrowing of the airway. So very bad cough and breathlessness. These are the common manifestations. Suppose lung parenchyma, pneumonia, how commonly they present? What are the common presentations of pneumonia?
They present with tachypnea, subcostal retraction, intercostal retractions, or fever.
Again, Mahima, this depends upon the severity of the disease.
Yes, sir.
Suppose mild anemia, mild pneumonia, fever, right? Breathless tachypnea, there may be the chest pain, right? And severe, then there may be the indrawings. If still severe, then there may be the cyanosis. But cyanosis is quite late in the case of the pneumonia. In pleural effusion, it's a mechanical problem. Therefore, it's a just breathlessness. No signs, nothing is there. And why interstitial disease, how they present?
They present with chest pain.
If I remind interstitial disease, they have the minimal receptors, cough receptors, therefore cough is minimal. But with the interstitium, mainly creates a problem with this gas exchange.
Yes.
And therefore it starts with the cyanosis.
Yes.
First, breathlessness. As this disease process increases, cyanosis, and may not be the chest size. So now I think if I try to explain from only the three symptoms, breathlessness, easy fatigability, and bluish discoloration, probably it should be some of the respiratory problem. To me, it comes first as the respiratory problem. But of course, medicine is quite complex, not that easy the way in which we are discussing. So we'll have to keep the mind open. But I think simply from the three complaints and the duration, if I take for the analysis, probably it favors that some chronic interstitial lung disease is likely, which started long back, and therefore gradually there must be the breathlessness, easy fatigability due to hypoxemia, and now it has resulted with the severity in the cyanosis. I think that's simply from the three symptoms we can explain. I think I will request other friends, specialists, please, before we go for further the story, you can put your, I will say express your inputs for further some ideas or thoughts, please. Dr. Amitos, please,
Yeah.
You can start it.
As per Wright said, it looks more like a respiratory pathology, but we can take it on a cardiac aspect also. Since we have two aspects, it could be either respiratory or it could be cardiac. There could be two issues. So if we have to rule out, since the child was having breathlessness only on exertion and not at rest, so it little bit favors to me like towards a little cardiac. And easy fatigability and decrease playing since 6 to 7 months. So even if some of the diseases like which are like delayed presentation of cyanosis, like some top physiology, anything, or which leads to a progressive infundibular stenosis is there. So initially the cyanosis might not be that severe, which is because cyanosis will appear only when the saturations are less than 85%. So he might be having a saturation of 87, 88, 90%. But when he is exercising, so there's not enough blood supply to the to the lungs, and that's why he's not getting that much oxygen. He's becoming breathlessness, and later on this is becoming more and increasing more and more over a period of 6 to 7 days. And finally, when the obstruction has become more severe, then he has started to develop cyanosis at birth. Only thing in the history part, you should have asked is whether when he was having breathlessness or exertion, whether at that time cyanosis appeared or not. That is a very important point.
Yeah. I think Dr. Amitos has given a very good idea to us that even how we can consider that some subtle presentations of the cardiac conditions are also to be considered. You're absolutely right. I think apparently what our thought process, but these are the presentations with the cyanotic cardiac conditions are also there. And you know that at the time of the breathless, if you see, there may be the appearance of the cyanosis. If the parents have noted, probably that will help us. I think this is just our preliminary thought process from the three symptoms only. As we got the more information, as we go for the examination, probably will become more and more clear. But what is our idea? That medicine should be started with our thought process. And as we get the information, it should be dynamic, it should be changing. And I'm sure that if we learn that type of the method, that helps a lot even in this era of this advanced technology. Sometimes technology may fail, but I will say your thought process may be right. So that's the point which we just wanted to instill to the students and to all of us. Thank you very much. Should we go further, sir, Dr. Amitos? And I think one more expert person is there. Sorry, I could not look at. I think Dr. Parenchyma.
Yes, good evening, sir.
Yeah, sorry, I could not see you on the screen, but I know that I think something else you can delight with some information, please.
Good evening, all of you. I hope I am audible to all of you.
Yes.
Thank you. And it is a very good presentation. I would want some little clarification here. Because breathlessness on exertion since 1 year. Which type of exertion the child have a 1-year-old child? Which type of exertions you find? Because the child of 1 year will usually we do not expect to run, go to up a stair. So which type of exertion is leading to breathlessness?
Sir, on running.
How to expect a 1-year child would run?
No, Dr.
No,
Parenchyma,
sir,
I
he
think
is a 5-year-old child.
yeah, here the duration is 1 year,
Hmm.
age is 5 years, so probably the problem started at the age of 4 years.
Okay. So it is little bit confusing since 1 year of age. So I would thought it is since 1 year of age. Okay, good. So one of
But sorry to interrupt you, but you know in the exam it can be different also. So Dr. Mahima, you can answer this question in some other child, suppose you were at the 1-year-old child and the breathlessness or exertion, then how they will complain. It is very rightly, sir. It's a question is good. And I'm sure in the exam somebody is going to ask you. So suppose in short the child who is not walking, in that type of the child, how will you elicit the history of breathlessness or how they will present? What will be the complaint? Am I right, sir? That's the question.
Yes, because there little confusion. I thought
Yes,
it
yes.
is since 1 year of age.
No, I think that here in this case, it started at the age of 4 years, according to her, because now the child is 5 years. But I think let us even make this point clear. At some other time, it will be useful. What I mean to say that younger the child who is not walking, but still there is some condition making the child breathless, and how they will present or what will be their complaint or what you should ask them to make this clear. So Dr. Mehma, you can take it.
At younger age of 1 year or younger than that, the child will present with suck cycle. That
Very
the
good.
child will suck for some time and then stop and then again start for sucking. And there will be excessive sweating on the forehead.
For which condition? Cardiac or pulmonary condition?
For the cardiac cause.
And then what happens in pulmonary? Suppose there is a case of the bronchiolitis. In that case also there is the breathlessness. In a case of the shunt, suppose as you say left to right shunt, patient is going for suppose some cardiac decompensation or failure, and that may be presenting breathlessness in this way, as you said, this suck-rest cycle. But is it for only cardiac or pulmonary or both, or what happens in a pulmonary condition? Make the point clear.
And in pulmonary, it will vary based on the condition of the child. It is based on the severity of the condition. Most of the child mostly come to us in the severe condition, that is with difficulty of breathing.
Not necessarily, Dr. Mahima, it can come with the mild bronchiolitis. Not necessarily the OPD, they come with the mild bronchiolitis, not severe.
But the breathlessness will not be there in mild cases.
Mild breathlessness can be there in a case mild bronchiolitis. Tachypnea can be there. Mild withdrawing can be there.
Yes.
Right. Actually, what just point, let me be clear, then Dr. Parenchyma will take.
Yes.
In a cardiac condition, what happens that the cardiac myocardium has failed. Am I right? It is not able to cope up the requirement or the demand of the body. And therefore, baby is trying to suck because baby has to take the nutrition. But once the sucking starts, that is the exertion for the baby. And with that, it becomes breathless. So it stops to suck for some time. That means taking the rest. I think cardiac condition, getting at least some energy, and then again baby starts to suck. So that is very classical story of myocardial failure, right? In any situation, it would be the behavior would be like this. But in a case of pulmonary, there is a constant pathology remains. Suppose if you take the example, easy for us to understand bronchiolitis. It is the, you know, that inflammation, narrowing of the bronchioles is going to remain. And therefore, it does not make the difference. On the contrary, with the severity increases, initially child starts to take the decreased fluid. Then takes even the child is not severe suppose hypoxemia, child will not be able to take the fluids at all as the severity increases. So that of the story will indicate that this is likely respiratory hypoxemia, and this is likely due to the myocardial failure. So in that case, if you go into details, talking to the mother, you can, and rest of the points already you discussed very rightly, sweating and other things, you can take the help for the differentiation. Dr. Pradeep, you can take it further, sir, please.
Yeah. Thank you, sir. You are already highlighted most of the point. I just want to put 2 or 3 points, Dr. Mahima. If there is a breathlessness from respiratory point of view, we have to think whether the problem is persistent or it is a in between episodes. How the child in between the episodes. This is a very important from the respiratory point of view. Second is that your child also has cough. So I would suggest, because in a history of present illness, you have presented there is a history of cough for last 5 to 6 months. So it would be better to present as a presenting complaint and then describe in details. On the basis of these 3 complaints, obviously the most of them saying it could be respiratory, it could be cardiac, and third I would like to add, it could be vascular, like the pulmonary hypertension. They may present like these 3 presentations. So if you added the cough symptom here, it will also broad your differential diagnosis, and it will helpful into the dissecting your respiratory versus cardiac versus your that is the vascular disorders. This is
Absolutely. Absolutely. I think he added that's a very important point to make it generalized, and we should keep in mind. Thank you very much. I think should we go further because we are at the only first slide. Yes, Mahima.
Patient was apparently all right 1 year back. Then parents noticed that child was becoming breathless on running. Gradually, breathlessness had progressed and he was getting breathless and walking upstairs and long distances. He used to stop after walking up 5 to 6 steps or around 100-meter distance. It was aggravated by physical activity and relieved on rest and lying down position. No seasonal variation seen.
I think now what is your idea, Mahima? Because you have described some details. I think upper parts okay. But you said that it was aggravated by physical activity, relieved on rest, and particularly on the lying down position. I think very rightly you have described. What does it suggest? What does it indicate? You can take it further, what we are discussing.
So it means there is increased oxygen consumption when the patient is doing activity, and on the rest the oxygen consumption is less. So it is relieved. The exertion is relieved on taking the rest.
Is there any specific pointer which you have mentioned that one is relieved on rest and second very specific position on lying down position?
Lying down position.
But why the child is getting the relief on the lying down position? It will not be, I will say in some conditions yes, so that you can elaborate properly. That what does it indicate?
Sir, in upstanding position, some shunt works higher, and there is mixing of blood in upright position.
Okay. In some, I think if I make it simpler, Mahima, and even straightforward, in which condition, with this particular lying down position or squatting posture, child is getting the relief?
Etiology of failure.
What does it indicate? What I mean to say, what does it indicate?
In lying down and squatting position, there is decreased venous return to the heart and increased oxygenation, which lead to the decrease in the symptoms.
So I think what Dr. Amitas was suggesting us, and that's why I said that if you as you get the more information, your thought process will gradually become more sharpened. I think here what you said, even you must have asked one more point. Only in the lying down position or something more? And I think there may be something more. Child is managing itself. It's not asking us, or according to our, I will say, advice, child is managing. The child has adapted that by this condition, by this position, is getting the relief. and that child has adapted by its own. And that if you ask the mother, probably you may get more information. Anyway, but I think here, just to make it clear, as the Dr. Amitos was mentioning, probably it indicates some Fallot's physiology. That disorder may be connected to the Fallot's physiology. I think that point becomes clear from this, and we may try to think in that direction. Medicine is just, I will say again, if I remind you, it's a process of thought process. And once you get some more information, probably it becomes clear. It may not probably require even the investigation. Investigation is just for confirmation. It's a confirmation that what I'm thinking is right or wrong. Suppose something, then you'll have to go for further thought process. So I think that's the thing. Anything further you can take, then again we'll be back to the experts. You can go for next slide. Mahima?
Yes, sir.
Okay, go for the next slide.
Okay, sir. Since last 6 to 7 months, he was getting tired easily and had decreased playing activity. Since last 1 month, he was unable to do routine activities efficiently.
Okay. So I think simply it indicates it's a progressive disease, right? So whatever the condition, simply you can interpret it's a progressive disease. I think you can take this slide, then again we'll go for the discussion. Yes, please.
He also had frequent bouts of cough since last 6 to 7 months. 4 episodes were present in 6 months, each lasting for 5 to 6 days. It was dry, intermittent, non-spasmodic in nature, no diurnal or positional variation, not associated with chest pain or hemoptysis, no aggravating factors observed. For the above complaint, patient was given OPD-based symptomatic treatment multiple times with partial relief of symptoms.
Okay. Next.
15 days prior to the admission, child had acute febrile illness which lasted for 3 days associated with cough and cold which got partially relieved by medication. After this, mother had noticed bluish discoloration of lips and nails. It was persistent with no aggravating or relieving factor. It was not associated with distress at rest. They took consultation nearby where sonography of heart was done which was normal.
Okay. I think you have provided very bold information, and I'm sure that these experts will find some good point to discuss. But I think before we go for the expert, any more information? Or I thought that if you complete the information, we'll go for the discussion. What is the next slide?
There is no history of any cyanotic spell, suppressed suck cycle, excessive sweating, orthopnea, chest pain, edema of feet, oliguria, or exposure to any accidental drug or toxin, convulsion, unconsciousness, allergy, or need of frequent nebulization. No history of admission in the past.
Okay. I think you can just stop sharing over here. Just stop even. For a while, Vima, can you manage to stop sharing?
Yes, sir. Yes,
Let us go to Dr. Amito. Sir, how will you take it now with this information?
So with now with as per this is with history that his breathlessness is only on exertion relieved on rest, and now he's having a persistent of cyanosis. More favors a little bit of a cardiac physiology is taking place. Only thing it is what is going in negative is only your history that the echo was normal. So if we consider the echo report was absolutely normal, and you have a cyanosis, so the only condition which comes, one thing which comes to my mind, either there's some subtle things which we are missing in the echo, or it could be a case of like a pulmonary AV malformations, in which you can have cyanosis, but the echo would be absolutely normal, and the child would be presenting with breathlessness, cyanosis at rest. This could be a formation, or if something is missing in the echo, then there could be some things like it could be an LSVC draining into the left atrium, or it could be an unroofed coronary sinus. So this is the few conditions which we would need to do it. If it is a case of pulmonary AV malformations, then he should have, if a bubble contrast echo would have done, that would have ruled out the thing. So as per this thing, I have my physiology. There is no pH, no pulmonary hypertension is here since echo was normal. So normal echo with the cyanosis, I would first consider a pulmonary AVM as my first possibility.
And so, is it so that not so common in the practice?
It's not
I
that.
think for general pediatrician point of view, I'm talking for your cardiologist, maybe the common, but I think for the general pediatrician, like me,
it is not a very, it's not a very common thing to see with the pulmonary AVMs, but definitely.
And do you expect some cardiac failure in a case of AV malformation?
No, we don't. There's no cardiac failure in AV malformation.
Okay.
Because there is no cardiac output is absolutely normal in this.
Right. So what sir mentioned that with this your information, Mahima, if we consider the echo which was done, we hope or we consider with the respect that the person must have done it the details, and if it is normal, then this type of some uncommon cardiac possibility remains. That is number one. Or commonly probably, as he said, the malformation or some very uncommon conditions you can consider. I think before I go to Dr. Praveen, Dr. Mahima, suppose some examiners will talk in this way. That is, why not the Eisenmenger complex? Maybe some shunt.
So Eisenmenger complex
and with this pulmonary hypertension, now the patient has gone for this reversal of shunt, and therefore the cyanosis is developing. So basically, it's a cardiac condition. Of course, echo remains, I will say, considered for a while that it is not known or we don't know. But clinically, if we just consider, is it possible some shunt? And which now the pulmonary hypertension and Eisenmenger complex and therefore cyanosis and breathlessness. Probably again it is little bit early, but even it can happen. Suppose in the exam somebody is asking, how will you explain? Yes or no?
Sir, there should be features of pulmonary artery hypertension like oliguria, edema.
Before that. Just I'm giving the hint. In the exam, I'm giving the hint to every student. You know, pulmonary hypertension, this reversal of shunt develops later on. Before that, shunt should be there. And if shunt is there should be some manifestations. Right? Am I right?
Yes,
suppose in a case of VSD, and VSD later on go, but if VSD, there should be some manifestation of the VSD first, and that will manifest early childhood.
Okay, at the newborn stage.
Later on. So I think let us first take this clarification from Dr. Amitos, and then we'll go further. Sir, please, you can highlight this point.
See, Eisenmenger syndrome, a typical classical Eisenmenger syndrome, you will have a feature of initially a phase of cardiac failure would be there. That would be he will having a suppressed cycles, sweating over forehead, recurrent chest infections, failure to thrive would be there. Then there would be a phase like after 1 year of age in a classical Eisenmenger syndrome, which we take a VSD, right? So, and then he will be a phase of an asymptomatic phase will develop. The child becomes absolutely asymptomatic because the pulmonary artery pressures have gone up. So there is no effective shunt taking place, neither left to right, neither right to left. So the child becomes asymptomatic. And once the further increase in the PA pressure begins to increase, and then when the right to left shunting starts to take place, and then the child starts to develop cyanosis. Initially, he will have cyanosis on exertion because PA pressure will get elevated that time, and then he will have cyanosis at rest. So this would be
yes, sir. Please continue. Sorry.
So this would be a classical natural history of an Eisenmenger syndrome symptom baby there. But there can be exceptions also, like in this case, they can like if the initial PVRI doesn't fall much, so then the child may remain asymptomatic and then later on he might have subtle signs and he may have later on develop Eisenmenger later on. So usually, but a classical, for examiner point of view, for a pediatrics exam, you should tell there will be initially symptomatic phase, then an asymptomatic phase, and then cyanosis. This is what you're
Absolutely, absolutely. So beautifully, sir, explained. And all these students, those who are on the attended link, or like he says, Dr. Yogeshwar said, YouTube, please remember, and I'm sure that this is not only for exam, but for clinical thinking also. The shunt is going to be there and it is going to be manifest. As sir said, occasionally shuttle without minimal or mild symptoms. I think that is for the super specialty, like Dr. Amitos, not for me. But I think commonly I will get this type of story, which I'm sure that if you describe the exam. And very important point what Dr. Amitos has mentioned, please remember, sir said that with the initial manifestations of the shunt, the time will come that apparently it looks that the patient is improving. And that's the biggest mistake by the parents as well as some of even our parents consultants. It's not the improvement. Shunt, even the murmur, which murmur was supposed almost continuous or even pansystolic. In a case of VSD, if you are talking, that the pansystolic murmur, that duration is shortened. I think it's not the point for us to be happy. It's a time for me to refer to Dr. Amitos, that before this pulmonary hypertension and irreversible and complication develops, he has to intervene appropriately. So as a general pediatrician, I think we should be very clear. And sometimes parents also, they will come after a few years. And when you are asking, they will say, sir, child was better. But all the problems which we were coming to you, they decrease very much. It is not going to be the normal child. And during that time, if you look at the growth chart, that will show that the child was not growing at all at any time. On the contrary, severe growth affection was there. That means there was the problem of hypoxemia, there was the problem of cyanosis, there was the problem of this decrease, supply of the nutrients due to this cardiac problem. So it is very beautiful story, I think sir has mentioned. Dr. Praveen Kumar, now we'll be back to you. We'll have to take further how we can explain this story, what Mahima has described.
Thank you, sir. Thank you. Before going to my differential diagnosis, I would like to clarify few queries regarding the cough.
Yeah.
Was the child completely normal in between the cough? Was it associated with any noisy breathing, according to the parents? Did you find any relationship with the feeding? Means if the child, if we are taking any feeds, the child develop any cough or any breathing difficulty? What you have mentioned about the response to relief with the medications, I would like to know in detail which kind of medications giving some relief to this patient, because it will help in doing the differential diagnosis. So before going to differential diagnosis, I would like to know this 3 or 4 queries from you.
The child was asymptomatic between the episodes. There was no cough episode during the feeding. Third thing, that the medication which were given, the antibiotics were not required all the time.
Then what kind of these medications? These are bronchodilator, these are nebulizations, these are just antihistaminic. Which kind of medication giving relief to this cough?
Most of the time antihistaminics were given.
Okay, that's good. And one last question, is there in history, environmental history of any exposure to dust, to the bird, or to any other allergens in nearby homes or in a homes? Did you get a history about that?
No, sir, there was no such history of exposure to dust or pollen.
Why I am asked these questions? Last question, why I have asked about these questions?
To rule out asthma, atopic asthma.
No, not at all. Only not asthma. Because your child also have bluish discolorations, breathlessness. Okay. I was asking about one of the entity that is hypersensitivity immunities, but I do not want to name here because I want very simple. Now, after going through the history and taking, I would still think it could be respiratory disease, but we have to exclude cardiac disease because many of the respiratory diseases also have underlying cardiac disease. Third, sir has told shunt. I would agree, shunt may present with that, but I would like to give a very important sign for the shunt, which we have seen recently, that is the orthodexia or platypnea. Child with the shunt usually have orthopnea, not orthopnea, orthodexia or platypnea. child remain well into the lying down position, but as soon as she sit down or has been standing, it becomes very much worsen. So this is one of the signs. So still I will think this child having some underlying respiratory disease, but we have to rule out cardiac disease because they may have some associations. And we have to keep about the shunt or any other vascular problem, including the pulmonary artery hypertension and other vascular malformations. Thank you. Please go ahead.
Yeah, I think let me give the compliments to our organizers, Dr. Yogesh Bhai, Nihal, and Rakesh Bhai, and all others. Do you know that they have organized so nicely that the common discussion for the general pediatrician like me, at the simultaneously both even the experts in different fields, one is cardiology and one is pulmonology. And you know they are trying to explain even the both the I will say conditions of both the groups. And as a general pediatrician, we have to try that how best we can derive or we can learn from both the people. I think this is really beauty of the discussion. I think what Dr. Praveen Kumar was discussing, it is very important for Mahima and all other students, and I'm sure even all of us are students, not only the, I will say, MD going exam. We are still students. Here what sir say that if you go in the details to the mother regarding the cough or breathlessness or symptoms, I'm sure that this child should never be totally all right. She said that in between child was symptom free and better. This child cannot be totally free from this any disorder. It is possible that the symptoms are decreased or minimum.
Maybe network problem.
Yes.
Internet.
So what sir is trying to say that child may have the decrease in the symptom.
Am I audible?
Yes, sir. Yes, sir. Please
Sorry,
go ahead.
sorry. I was this on the my connection had some problem with this incoming phone. What as I will say, general, we should ask regarding the activity of the child, whether the child was remaining active, playing, whether the child was eating normally, whether child was sleeping normally, whether child was growing properly. And I'm sure that if you ask, then mother will say, that's not so even playful, but yes, doing the activity. Not necessarily that the child is full and active. Parents, mother will say that not going to play with other children, just watching them. Going to the playground, but watching them, not actively playing. Or you are not eating properly, some food has decreased, intake is decreased, and not even remaining totally well. So I think in this type of chronic illness, what I want to suggest, either the cardiac, pulmonary, or any condition, there may not be the severe symptoms, but it's not totally child is normal. And I think as a general pediatrician, we'll have to detect the condition which is there with any chronic liver problem, chronic renal problem, chronic renal or cardiac or pulmonary problem. And I think in this patient, I'm sure that I'm waiting for the growth chart, probably which I'm expecting that it should not be totally normal. It should not be. The way because the child is suffering from this problem. Then that is a very important marker for the general pediatrician that whether I'm able to understand or not understand, whether it is the cardiac or pulmonary, but I need the help of some proper person. So I think inputs from both the experts really very delightful for us to learn. So I think here at this juncture we decide that maybe the cardiac, as Dr. Amitos tried to explain, as Dr. Praveen Kumar said, even some of the pulmonary conditions, at present probably we'll have to keep both the things in mind, which may be common probably. And with this equal normal, probably if it is right, we'll have to consider, I will say, in that way. So I think this is very important for the general pediatrician that how we can analyze. Thank you very much. Mahima, you can share further information and then we'll be back for the discussion.
Antenatal history, regular antenatal visits were done and ultrasonography was normal. Received iron, folic acid and tetanus toxoid. No history of drug intake, radiation exposure, diabetes, hypertension, thyroid disorder, fever, rash or leaking per vagina. The child was born to a 30-year-old female, third by birth order, born out of non-consanguineous marriage, full term, normal vaginal delivery, cried immediately after birth, 2.5 kg birth weight with no NICU stay. The child achieved milestone appropriate for age. Child was on exclusive breastfeed till 6 months of age. Complementary feed started after 6 months and child is on home-based diet since 1 year of age. His calorie intake was 1200 as opposite to expected of 1400 and deficit of 14%. And his protein intake was 16 gram as expected to 18 gram and deficit of 16%, 17%. He was immunized till 5 years of age as per national immunization schedule with no records available. He had 3 siblings who were apparently all right. No family history of owning any chronic lung disease, asthma or congenital heart disease. No history of similar complaints in the sibling, and socioeconomic status is upper middle class.
Okay, I think most of the points in the history we have discussed. Just for a while, Mahima, you know that nowadays in the DNP and MD examination, it is routine that the examiners will ask you at the end of the history that what is your thought process. Probably already we have discussed in detail at depth that regarding this cardiac and the pulmonary conditions. So I think you can prepare some short summary for the exam point of view. That this age group child, 5 years, presented with this problem of 1 year, started with the breathlessness, then this fatigability, and with this cyanosis of 15-day duration, with the rest of the points in the history are described. So I think you can put the hypothesis that it looks that some cyanotic disorder should be there. Even the cyanotic disorders, commonly they present with the cyanotic conditions that can be the fellow's physiology, and the disorders can be the anatomy. So that you can keep as the number one possibility. Or of course, you can say some chronic progressive, even the lung disorders also will have to keep in mind, and rare conditions remain at the last. So I think that type of the hypothesis you can prepare so that you can have the better idea and perform this habit, I would say, a daily routine round. That these types is at the short summary of 10 sentences, so that you can, I will say it's not diagnosis, it's a hypothesis that whatever the disorder or pathology you are thinking, right? I think, should we go for the examination, Dr. Amitabh? Yeah.
Just I want to give you,
yes, sir.
When we are dealing with the cyanotic disease and you're thinking it's a cardiac pathology, one must be very clear that whether I am dealing with a cyanotic heart disease with a decreased pulmonary blood flow physiology, or I am dealing with the cardiac cyanosis with an increased pulmonary blood flow physiology. That should be very much clear. And that should be evident in your history also.
Absolutely. Absolutely. Sir has pointed out very rightly. And you know that the one specific group you are targeting, that this group with a decreased pulmonary blood flow or increased pulmonary blood flow, that is one group of the disorder. And I think that from the history you should do. Yes, sir. Thank you very much. Now you can go for the examination, Mahima.
Child was examined in good light in supine position. Child was conscious, oriented to time, place, and person, with vital signs of temperature 98.2 degree Fahrenheit in right axilla, pulse 90 per minute, regular in all 4 limbs, with good volume, with no radiofemoral or radioradial delay. Respiratory rate was 26 per minute, which was regular. Blood pressure was 100/64 in both upper limbs and lower limbs. SpO2 was 74% in all the limbs. Anthropometry, his weight was 11.6 as expected to 18, which was less than -3 standard deviation with a severe wasting. Height of 96 centimeter as opposed to 107 centimeter, which was less than -3 standard deviation, which falls in severe stunting. With head circumference of 51 centimeter, which was expected to be 50 to 51, which was normal. In weight to height is between -2 to -3 standard deviation. In head to toe examination, the
Dr.
head appear.
Dr. Mahima, have you growth chart?
Yes, sir.
Have you brought the growth chart?
No, sir, I have not brought the growth chart.
Therefore, sorry to interrupt you, but for all these students, even you may not plot it, but at least show the growth chart to the examiner. And in the MD examination or the DNB, now without the growth chart, probably it remains totally incomplete examination.
Okay, sir.
And it is expected on the contrary, postgraduate students that very rightly plotted proper interpretation. Right. Here, I think you have made this anthropometry examination very rightly. We'll go for the discussion later on. You can continue, but just to brought these very important points to notice of everybody. Please.
In head to toe examination, head and ear appeared normal. No dysmorphic face. Plethoric face was there. Eye had hyperemic conjunctiva. Ear, nose, and throat were normal. Lips, gum, tongue, central cyanosis was observed. Teeth 20 number, no dental caries. Neck, no lymphadenopathy. Nails were cyanosed. Clubbing grade 3 was present. No pedal edema. External genitalia normal. Bilaterally testis descended. Back and spine normal. So should I proceed?
Or I think we can complete this simple, the general examination. Mahima?
Yes, sir.
Can you go for the, or stop sharing, I think?
Yes, sir. Yes, sir.
Sorry, you know that in classroom discussion, we are talking with each other. We have the patient, we can examine, we can confirm the findings, but I think that part is lacking on this online discussion. But why I'm asking you to stop sharing, I think at least we can see each other and we can have this some live discussion. Regarding this interpretation of these vitals, what would be your point, Mahima? I think we can take one by one segment. First vitals, then
Okay,
growth, then general examination. And I think then it will be the clear picture in the mind of all of us. So what is interpretation of the vitals?
Sir, on the basis of
Normal or abnormal?
Sir, only SpO2 is abnormal, that is 74% in all the 4 limbs, but BP and pulses are normal.
Okay. I think you can say that rest of the things at least within normal range.
Yes, sir.
Not necessarily normal,
Yes,
but at least you can say apparently. And that SpO2 level is low. What does it indicate? What will be your interpretation?
SpO2 level is low. That is, there is reduced hemoglobin. There can be some reduced hemoglobin in the or decreased oxygenation.
I will say, why not this? It is a respiratory problem. Cyanosis due to the respiratory cause. I will take in this way. Why not? When respiratory cause can also make the cyanosis.
Yes, sir. It can be a respiratory or cardiac.
Sure. Then we'll have to go to the experts. That what points are favoring you to say the cardiac, which points are not favoring you to say this respiratory or pulmonary. Are there certain points from which clinically even you can say that it is more suggesting cardiac or pulmonary? I'll just give the hint. Any idea to your mind?
Sir, in respiratory, the RR should be increased. But here, respiratory rate is normal.
You know, again, if I remind you, Mahima, please remember the basics. There are 4 components in the respiratory: airway, lung parenchyma, pleura, and interstitium. Among all the 4, which component will make the child cyanose without the increased work of breathing? Suppose simply if you take it, I think you must have seen numbers of patients of bronchial asthma. They have severe bronchial asthma, but no cyanosis. And once cyanosis is there, I think quite different situation. Am I right? Because they develop this airway narrowing, increased work of breathing, cyanosis at large with a severe, where probably we fail to manage. And that patient, probably before that, it should be the ICU. Right? So with the 74, if the patient is sitting to you, talking to you, right? Just like, suppose one example, we have taken the airway disease. Suppose lung parenchyma, pneumonia, simple. I will say general pediatrician, please remember pneumonia. Pneumonia patients, you must have seen plenty of patients in your general ward. How many patients develop the cyanosis? No. When they develop probably extensive pneumonia, bilateral, viral, we fail to manage, patient goes for respiratory failure, then leads to the cyanosis in a case of pneumonia, not generalized routinely. Am I right? Yes. You must have seen patient of massive pleural effusion in a case of tuberculosis. One side is opaque, still not cyanose. Am I right? Yes. So probably with the severity increased work of breathing, you may get it, but then condition of the patient, clinical picture will be different. And even interstitium can make it. Interstitial disease is possible at minimum symptoms, minimum signs on examination, but SpO2 is low. And that is very classically, I think, for general pediatrician like me to remember, miliary tuberculosis. Miliary tuberculosis is an interstitial disease. And therefore minimal complaints, even chest size hardly few scattered crepitations. But hypoxemia is there. SpO2 is low. Or even suppose in a case of sarcoidosis, if you have got this interstitium, many a time they come with this very low SpO2, but child is sitting in front of me. So what I mean to say, among all the 4 components, respiratory system, interstitial disease, whatever it is, even viral pneumonia, they can present, but with that even other symptoms or other manifestations are expected. And therefore probably very simply, as a general pediatrician, we can say that pulmonary with this presentation is less likely. Right, I think that should be your answer. With that even, you have mentioned some of the points in general examination, growth retardation. That's why I wanted to growth chart. Growth chart, obviously, rather than figures, if you put on the chart, it shows exactly the growth. I'm sure that severely must be the compromise, because these child never got the good oxygenation, whatever the pathology. And for cellular function, it requires a good nutritive substances, good oxygen level, and glucose. Once they are affected, the cellular function and growth are affected. And with the chronicity, they are not allowing the child to grow. So that's a very important. Here, I think you have mentioned head is normal, but height and weight both are affected. So definitely it's a chronic disease, chronic hypoxic disease. Whether it is related to cardiac or pulmonary, that we can go still even in the examination. I think some of the points are examination general also. Again, let us go to learn from both the experts. Dr. Amitos, I think you can take first, and then Dr. Praveen Kumar, that how you will take with these findings.
Yeah, with the journal examination, definitely it shows there's a chronic disease is there, as sir said, because there is both weight and height are affected. Chronic hypoxemia is there. There's a low saturation central cyanosis is present. Clubbing is there, grade 3, and pulses are absolutely normal. But I just want to mention that your pulse examination is not appropriate. Pulse has to be told in 8 points. What is the rate? It's like you said 90 per minute. It should be regular, normovolumic. What is the character of the pulse? That is also very important to describe, because a lot of conditions you can describe. I have a cyanotic heart disease with a collapsing pulses, right? So then, so the pulse has to be more elaborative. That's what I feel. But definitely, this point would suggest, it's like cardiac points would suggest a child is not tachypnic, low central cyanosis, clubbing, more, and with chronic stunting and growth failure is there. So these are the points which suggestive of cardiac lesions. Only one thing which it had been is the dysmorphic faces. There's no dysmorphic faces. So I would also ask, what are the cyanotic syndromes which are associated with cyanotic heart diseases?
Yeah.
Down syndrome, Turner syndrome, Klinefelter syndrome, Williams syndrome.
I'm just very specific. What are the syndromes which are associated with cyanotic congenital heart diseases?
Cyanotic congenital.
Mahima, sir has considered you as a good candidate. Suppose average, his question will be like this, that dysmorphic features and congenital heart disease. But here his question is very specific. That means he's considering that you are above this level. And he wants that dysmorphic features and cyanotic congenital heart disease, not any congenital heart disease. So with that thoughts, what will be your answer? That means some syndrome, find out with the cyanotic heart disease.
It's okay. You can take that as your homework also, no problem. You can make a list.
Okay, you can go further. I think Dr. Parenchyma, you can take it further from your stand, from the general examination point of view.
Yes, good discussions. After going through the general discussion, child have the cyanosis but not tachypnea. I would expect tachypnea, but it is not there. Sir has very brilliantly explained the lung pathology in a 4 group. I will take you any further on the basis of physiology, and if you see whether it is matching or not matching. This cyanosis is actually a result of hypoxia due to the lung disease. No hypoxia will be not cyanosis as per the lung disease. So if you see the hypoxemia causes, there are 5 more causes, and you try to fit into them. One is due to lack of oxygen into the environment, or maybe due to the hypoventilation. In this, you will not have any tachypnea, and you will get cyanosis after hypoxia. Second is the defect in the diffusion, which is talking about the lung disease or interstitial disease or parenchymal disease. In diffusion, you will have some degree of tachypnea because it is a chronic disease, apart from the cyanosis and hypoxia. Third is the BQ mismatching, that is a ventilation perfusion mismatching. And it is very common in asthma, pneumonia, bronchiolitis. You will see daily basis. This is the most common cause of the cyanosis due to the respiratory cause in our daily practice. Fourth group is the shunt. Again, in a shunt, you will not get any tachypnea, just turning a cyanosis or clubbing. And fifth group is that is the extraction, increased extraction into the peripheral tissue. And in this, again, you will not find any tachypnea. So try to find out what could be on the physiological basis, what could be the underlying pathology. So definitely it is not due to the diffusion defect. It is not due to the BQ mismatching. So left only 3, it may be hypoventilation or decreased air and oxygen into the environment. Second, it may be shunt. And third, it may be the increased utilization of the oxygen into the peri. So these are my point from the respective point of view. And obviously, we have to think about the cardiac disease that may cause the cyanosis.
Yes, yes. Brilliantly, Dr. Parenchyma explained, and I think all of us should remember that just from the clinical point of view, but you can differentiate. And I think really, I'm very happy to see, even in spite of the super specialist person, otherwise we have a general impression. I'm very sorry that super specialist people are less interested in this general, you say, examination or history. Just they will say that show me the echo, show me even this some CT scan or something. But we are fortunate that both the people, you know, how at depth they are able to explain us this beauty of the medicine. And I'm sure that this will add to our knowledge. Case is just illustration. It's just example for us to discussion. But besides this case, we are learning many, many points. And brilliantly, both of them explain us there so nicely, even from clinical examination, you can make out. Thank you very much. I think now you can go for systemic examination. We'll have to keep in mind the timing also. Mahima,
Yes, sir.
you can share this your PPT and systemic examination.
Yes. Firstly, I would like to go for cardiovascular system. On inspection, the chest was elliptical, symmetrical abdominothoracic movement with RR of 26 per minute and regular rhythm. Apical impulse visible 1 centimeter below and lateral to the nipple. JBP is not visible. No visible pulsation, precordial bulge or scar mark on any chest deformity. On palpation, apex beak felt at fifth intercostal space in mid-clavicular line, parasternal heave and thrill not palpable. On percussion, right heart border present in right parasternal region and left till apical impulse. No cardiomegaly appreciated. On auscultation, first and second heart sounds normal. No murmur or added sounds heard. On respiratory system, bilateral air entry is present. Chest is clear with no craps or any other sounds heard. GI system and CNS are absolutely normal.
Okay, you can do your summary also.
Okay. A 5-year-old severely vested and stunted male child with chronic hypoxic illness supported by progressive breathlessness on exertion, plethoric phase, conjunctival congestion, central cyanosis and clubbing without any evidence of respiratory or cardiac abnormality on systemic examination.
So in the CVS, you have not got any murmur or anything. Am I right?
Yes, sir.
Okay. Can you just stop sharing before you show the investigations? Let us discuss this CVS finding. I think just because we have the short time and we want to utilize, let me go directly to Dr. Amito. Sir, how will you interpret these CVS findings and even explain to the students regarding some CVS points or examination, please?
So see, as far as her CVS examination concerned is normal. So when you have a precordial is absolutely normal. There's no precordial bulge or null is present. So basically any bulge which is present, it indicates that there's a cardiomegaly was there, which is present for a very long period of time. That's why there's a chest deformity is there. Otherwise, there would not be a much chest deformities would not be present. As for the palpation is concerned, it is very important to palpate before doing any auscultation in a cardiovascular. You can make a diagnosis on palpations, right from where is the apex beat is it, from which we can make whether it is right ventricular dilatation or a left ventricular dilatation is there, right? A down and outward apex beat, and the character of apex beat is also very important to determine what kind of apex beat is a tapping apex beat or it's a hyperdemic apex beat. Then is the most important is the palpation of a second heart sound, which you have not mentioned in this, whether you were able to palpate a second heart sound in it. Palpating a second heart sound means that the P2 component is very loud. So if you have an Eisenmenger syndrome or a condition, a palpation of a second heart sound will tell you that there is a loud second heart sound component is there. Third is even we have thrill is another, which you had said there's no thrill, which means a palpable murmur it is there. And a parasternal heave, which tells us whether the right heart is dilated. This again a confirmation, right heart is dilatation or not. But at the same time, in both an inspection and palpation, you should have also mentioned whether there were epigastric pulsations were there or not, or you could feel the epigastric pulsation, because that is also an indication. Sometimes you might not have a parasternal heave evident to you, but when you insinuate your fingers, it might be hitting your heart and you might be missing this thing. And then auscultation also, just first and second heart sound examination is very important, especially the second heart sound component is very important, because a loud P2 would be, whether the S2 was single, whether S2 there's a or there's a loud P2 component was there, whether you heard an ejection click was there or not, because that would be, because if it is the top physiology, you will have only a single S2, right? Whereas if it could be a severe pulmonary stenosis with an AS, it could be associated with an ASD, which because the PS has severed, you will find initially a ejection click would also be there, and you will find a split in the second heart sound will be there, which will not be a top physiology. There would not be any split. So it will tell it's a valvular thing that you can differentiate. It's a valvular, or it is or just a single S2 component, right? So these are the few things which you could highlight highlighted. And as per your, I think this examination, it shows if the cardiovascular system is absolutely normal as per this. So if with normal this there is, and considering the cardiac physiology again, then I have my consideration is keeping it again by the same differentials I would keep in this case. That is, would be the first pulmonary AV malformations or what we have. Then second would be a possibility of some LSVC on an unroofed coronary sinus opening into the LA, which could be there.
So I think very nicely he explained for the examination. I think for all the students for DNB and the MD, please remember, and you know that at least short case of CPS, almost everybody is going to get it. And you know, examiner is never interested in the diagnosis. On the contrary, even you may be the diagnosis. Sometimes in lighter mood, I tell to my students that I will give the case today, Saturday. Next Saturday, we'll take the exam. So now you can examine this patient all the 7 days and then we'll discuss. Ultimately, what I want to convey, that examiner is interested that how best you know the pediatrics and even the best examination. And that cannot be learnt in a day or two. Therefore, I say that by giving the case or something, hardly it makes a difference. The point is that how methodologically you are examining. That is the first step, very, very important. Methodologically, any system. Then second, how you are interpreting your findings. And after this interpretation, how you are analyzing your findings. And based on the analysis, how you are deriving your functional clinical diagnosis or possibilities. And there remain the possibilities. Among all the possibilities, always keep the common conditions first. And then the less common, and at the last rare, as already Dr. Amitos did it, that how best you can put it. And I'm sure that if you are discussing in this way, even in the medicine also most of the times the practice will be right. And even the exam also right. So that's the, I think, message what he tried to convey to us. And very important point in CVS, besides all the points what sir emphasized, that very good inspection, then palpation. And therefore, you know, when the child is sleeping without disturbing, I think the pediatric is very, very important. Once you disturb, I think it's difficult for you to go for the proper examination and interpretation. Therefore, when the child is sleeping, take the opportunity without disturbing much, gather the more information on the examination. Later on, probably it may not be possible for you. And among all these, apex beat is very, very important, whether it is in where it is located and its interpretation. Similarly, it is said that regarding the second heart sound, it is important in MBBS, it is important in MD, and it is important in the DM cardio also. That this second heart sound is very, very important, and examination will provide lot many information, even simple clues for reaching the diagnosis. Whether it is the components P2 and aortic component, regarding this situation of the quality of these sounds, then regarding this distance, that is the splitting, and the splitting is really variable or fixed, loudness of the sound. You know, pulmonary hypertension, simply clinician will say from the P2 only. Then probably echo may show or may not show. So I think these simple points sir has emphasized very nicely, and I'm sure that if you keep in mind in the examination, it will create some different, I will say, impression to the examiners. I think before we go for further the investigation, let Dr. Praveen Kumar put his any points if he wants to add. Sir, please.
So, thank you, sir. I would expect more detailed respiratory system examination. You have just put it in a one line. It appears that you assume that you are dealing with a child with a cardiac disease, not examining the respiratory disease. So, actually, totally, it is unacceptable for the student. You have to take a detailed respiratory examination whenever there is a differential diagnosis of that. Second thing is that whenever doing the respiratory system examination.
Sorry, Dr. Pradikar, just a minute to interrupt you. I'm really sorry, but I thought it is very important. In one of the, I will say, very good panel discussion with all the seniors, I remember, one of the, even the expert person say that in my presence, how you can neglect my system. He said that you will have to justify it. And I think he was very right. It's very true, Dr. Pradikar. Please go ahead.
The cardiovascular was normal, so you should have more emphasis on respiratory.
Even retrospectively, you have to do the detailed examinations.
Yeah.
And then a point is that whenever doing the respiratory system examination, you have to do for both upper respiratory tract and lower respiratory tract. Suppose if this is an acute cases, it may be due to the upper respiratory tract problem, and we are looking into the chest, but the problem lying in the upper respiratory tract. So we should look for that. Second thing is that whenever you examine the respiratory system, please ask the child, please examine in the sitting position and ask the child to take deep breathing. Otherwise, you will miss the subtle crepitation and subtle wheezing, and you can miss very well. Even our student missed very well, and when we examine and around, and we find, yes, this child had a crepitation. So I hope you must have given the detail of the respiratory system examinations so that we can make a point. Otherwise, the examination finding is doesn't adding into the further differential diagnosis from my side.
I think very nicely he even clarified. Please never miss in the exam also. That many times, suppose if you're diagnosed some CVS or any condition, but associated or even without associated, some other situation may be there. Probably that we are missing, because once we are focused, that you are trying to search something. You got it, then you become, I will say, happy. And then you don't even bother to see certain other things. Many a times you are associated some other conditions may be there. And I'm sure that I remember in my rounds that it happens several times that because something you got it, even suppose simple, I will say the general pediatric hepatitis, it's a jaundice, even IgM hepatitis A positive, but the patient is not improving. Hepatitis A patient, we are not expecting that it should behave in this way. And I remember that one of the patients, I said that why you are not thinking some associated condition? And I remember that when we went for the workup, it was the Wilson disease. In a Wilson disease also hepatitis A. But hepatitis A patient, the course is different. Why I'm giving this example, recently we had this situation. And their point is, as a clinician, keep in mind that the way in which I'm expecting the findings, the way in which I'm expecting the course, the follow-up progress of this, even the effect of the treatment, if it is not there, that is also a very important point to keep in mind. Is it really developing some complication? Or really is it some associated comorbid other condition? Or probably something else, some medical disorders? Nowadays, lot many information we have, which were when we were students, we were not knowing even the ABCD name. But now with all the specialist people, we are learning that so many advancement has taken place, and to our utter surprise, we get some very uncommon condition. And therefore, it is very important that there is no substitution to the detailed history and thorough examination of every system. I think that is very important message. Thank you very much, both of you, sir. And I think now, I'm sure that Mahima must have some workup, so you can show us some investigations and we can come at least to know the condition, please.
Sir, I have not prepared a slide of any workup.
Very nice. I think that's good. I like it. You should not have. And then it becomes a very good clinical discussion. But I think you can share, suppose if you have something, I'm sure that at least workup must have been done in your ward, in your unit. Whatever you have information, But I think I request all the students in the future also that for our further learning, at least basic investigations or something, that part interpretation also will have to learn. I'm sure what hemoglobin you are expecting here, Mahuma, then my question should be there. Suppose I have done the CBC. What you are expecting the hemoglobin level?
Hemoglobin, the patient had polycythemia, hemoglobin of 20.
In this patient?
Yes, sir.
Okay, why it was 20? How will you explain?
Sir, there are congested conjunctiva is present, plethoric pace is present. There is chronic hypoxia, which lead to the increased erythropoietin and increased hemoglobin production.
But in one of my students, I remember, still he was giving the iron. Is it right or wrong? I said, why? Hemoglobin is 20. What do you want? But he was still giving the iron in this patient. Is it right or wrong?
Sir, I am unable to.
Mahima, you are registrar. I will say you are senior resident.
Okay.
And your junior resident has started in this patient with 20 gram hemoglobin, even oral iron therapy also. I think he has done the mistake. What you will do? How will you correct it?
Sir, in anemia, clubbing is not so prominent. Cyanosis is not so prominent.
My simple question. Would you continue that iron or you delete it? He has done the mistake. In this patient, your patient, with
sir, here is hyperviscosity due to the increased hemoglobin. So giving iron can increase.
No, my man. Sir is asking, can you have an iron deficiency associated with polycythemia or not?
Yes, sir, it can be associated.
So that's what sir is asking me.
It can be associated.
With the patient with cyanosis, can you have something in the what will you like this because the cardiovascular are absolutely normal. So I wanted to know per abdominally what did you could find something? What is the gastrointestinal thing which you can have manifestation which can be associated with it?
Hepatomegaly.
Why will have hepatomegaly with cyanosis?
In case of congestive cardiac failure.
But there is just no congestive cardiac failure in your case, no?
Yes, sir.
So you can have some. We are talking about thinking about like if the heart was normal, only cyanosis was present and there's no respiratory system. So you can have a. If I'm thinking pulmonary AVMs, so what could be the cause? It could be in the GI thing. Something which could be a positive factor for the development of pulmonary AVMs.
Any visible pulsations?
Visible pulsations for what? You mean to say pulsatile liver? Why you will have pulsatile liver?
No, sir. Pulsatile liver cannot be here. It is there in regurgitation.
So basically, this I want to answer. It could be some cirrhosis of some cirrhotic cirrhosis can also lead to formation of pulmonary AVMs. Some long-standing any condition which can lead to cirrhosis of liver can have this thing, and later on present with PVMs which lead to formation of cyanosis.
Dr. Mehma, is there any way by which you can differentiate between the cyanosis due to the respiratory cause or due to the cardiac cause? Is there any clinical method?
Hyperoxia test.
What is this test?
In this, we give 100% oxygen for 10 minutes. If it improves, then it is a respiratory cause. And if it does not improve, then it is a cardiac cause.
Okay.
And after that, we take the ABG. The ABG will improve.
If ABG facility is not available, then how will you do the hyperoxia test? Suppose you do not have the facility for ABG testing.
SpO2 monitoring.
Okay. Good. Okay, so what is the unit diagnosis for this child? What is the unique diagnosis of this child?
So there can be any shunt present which has gradually progressed, which
Yes.
was asymptomatic till now, and the patient is symptomatic now. The shunt function has increased now, which is progressive. It can be any AV malformation, or the top pink top has converted into a blue top.
Okay.
But
That's fine.
but there was but on your examination there's no murmur, no? There's no murmur.
Yes, sir. Yes, sir. So it rules out.
Sometimes hepatopulmonary syndrome, maybe some things in the some abnormal connection between the hepatic or the from the systemic artery not going to the hepatic system directly draining into the inferior vena cava. This type of shunt can present without any murmur, without any respiratory findings, and you may get something like that, cyanosis. So sir has rightly asked what you find into the GI system. So look for the portal venous systems. So how they are draining, whether there is connection, abnormal connection, which the aberrancy, that is the abnormal aberrancy connections which may present like that.
So what was your investigations, Mahima, in this case?
So initially ABG was done, in which the PO2 was less. It was around 69, 64 to 64. Then chest X-ray was normal. Later 2D echo was done, which was found to be normal. Then CT angiography was done later.
So what it revealed? Pulmonary AV malformation.
Yes, sir, pulmonary AV malformation.
But this could have been picked up in echo.
Bubble 2D echo.
Yeah, you have done a bubble 2D echo.
Yes.
In how many, after how many cycles bubble 2D echo would suggest it's a pulmonary AV?
After 3 cycles. After 3 cycles, it is normal.
Up to, so it appears like, yeah, so our book says it's up to 5 cycles. If it appears less than 5 cycles, so it is more suggestive of a pulmonary AV malformation.
I would like to highlight one clinical method. Can you diagnose the shunting even without the bubble echocardiography? Do you have any methods? Can you diagnose by the ABG alone?
On the basis of ABG, only PO2 and SO2 is decreased.
Do you know about the some alveolar arterial difference? Have you aware about the arterial alveolar difference? Alveolar arterial difference?
Yes, and there is perfusion defect.
Yes. So what happened to the perfusion? If you do the hyperoxia test, and what happened to this? That is the alveolar arterial gradient. So this is a very important test to diagnose the shunt or to suspect the shunt.
Sir, it is
yes, please go
it
ahead.
is increased. Arterial alveolar gradient increased in interstitial lung diseases or any.
Okay, so this is a very important differential diagnosis. So whenever doing the alveolar arterial gradient, and if you are giving the oxygens, if it in most of the condition, hypoxia condition or cyanosis condition, it will improve. It is the only shunt where the arterial, that is the alveolar arterial gradient remains same. So this is a very important bedside method which can give you a hint toward the shunting, somewhere is shunting. So never forget to do the alveolar arterial gradient. This is a very important test at the bedside.
Yes.
Thank you.
Thank you. Really, I'm extremely sorry. I again lost this connection. These are some hazards of the system, and it is beyond our control. But I'm sure that we learned a lot. Is there any point, Dr. Mahima, from your, I think, or even questions from Dr. Nihal or even Dr. Kirit? Questions from other students on the YouTube or these chat box?
Sir, there are no questions on YouTube. And
so I think then our experts have done the well.
Yes.
And Mahima has presented very nicely.
Yes, very good.
Yes,
I think before we end over here, any question from you, Mahima, to our experts?
Sir, any other DD which can be found in this condition?
Okay, ultimately what we decided that what is possible. whether it is the cardiovascular system or pulmonary. Many times it happens so that we are not able to decide even the system.
Yes.
In our medicine, at times it happens so. I remember sometimes I discuss one for 30 minutes, 1 hour, and next day even the whole system is getting changed. That the disease is not from that system. It happens so. So ultimately, what possibilities we are considering? Because I think Mahima has not shown us the workup in the ward.
No, so she told us that.
Acha, acha. Oh, sorry, I missed it.
So she told
Dr.
that.
Mahima can.
Yeah.
Sir,
Mahima,
sir, yes, you can carry on, please.
No, so Mahima told that they had done initially an ABG was done, which showed a low PO2s, and then they did an X-ray, which was absolutely normal. Then they did an echo, which was normal, but they did not do a bubble contrast in that. Then they went for a CT, which showed an AV malformation, sir.
Right. Oh. So I think from the beginning, Dr. Amitos was dissecting that without murmur, without much, with really eco-normal, and it has been interpreted very nicely. I think that's the story. And I think again, probably in our general period, it's not so common, but still, yeah, with this clinical picture or presentation, if you are aware, very rightly we can probably target it that this is one of the possibilities. So I think very good case, selection of the case, Mahima, on your part. And I will appreciate that you have presented very nicely. I understand that to face even the 2-3 experts for continuously more than 1.5 to 2 hours, and with the same, I will say, confidence and zeal, it itself proves that your ability. So I think you have done a very good job. Thank you very much. And I wish that other students should be there to present this. And I'm sure, we can learn maximum from the presentations. Probably all the points all of us may be knowing. Once we discuss, probably our clarity increases and we can remember for the very long time. And I think before I end, let me express a word of gratitude to both the experts, Dr. Amitos and Dr. Parenchyma.
Thank you, sir.
Thank you, sir.
I think so nicely, they because usually, to be very frank, being general pediatrician, I've been knowing more of the basics. Probably advancements may not be known much to us, but still I think you remained very nicely with the basics and even which we can reach to the advancements. So I think your contribution, I'm sure, was extraordinary for all of us to learn. And therefore, I think even the selection of both the experts is very, very appropriately done. Well, before I end, let me express our gratitude to Dr. Yogesh, Nehal, Kirit, and our President Rakesh Desai for giving this opportunity. Thank you very much, sir. Yes, Dr. Parenchyma, please go ahead.
I would like to suggest a student do one thing: make a differential diagnosis and make a positive or negative point at two places, at the end of the history and the end of the examination point. Make different, if it is a cardiovascular, make few differential diagnosis, make point in favor, make point not in favor, make a PPT like that. What we are doing here, it is very useful for the routine clinical learning. So at the end of the history and the end of the examinations, please do we call this POMR chart, that is the problem oriented medical record. This is very useful for the teaching as well as the learning. Please do it in a clinical practice. Thank you.
I think now, as Dr. Parenchyma mentioned, that there is the advancement in the technology of teaching also. And for that reason, we are coming up with different, I will say, aspects of the ways that how best we can do. And for that reason, simply probably years together, which we were using the terminology like analysis. Now that analysis in a proper format, the word, that problem-oriented workup, I think that's very rightly. You should have the thoughts or ideas. With this, suppose in the history, whatever the positive points. And always negative points, what we are mentioning, that they are very quite nearer to the differentials. And whether they are present or absent. Suppose present, it helps me to favor. If it is absent, probably it helps to me exclude. And by that exercise, at the end, you have the very few conditions. And I think most of the times you'll be right. So I think that approach even is absolutely right. And in the exam also, I always tell my student, spare some time for the thoughts. Otherwise, what happens at the last moment till the examiner comes, as you are measuring the blood pressure or taking the head circumference or examining something, and straight away examiner starts with bombardment of the questions, naturally nobody can answer. For us also, there should be some time for the thought process, or at least some ideas. And with that ideas, you try to put on the paper, as sir said very rightly, that even you can refer when you are talking to the examiner. Examiner wants that even you can refer, everything you may not be able to remember. And with the reference when you are talking, it becomes a very good, effective, impressive. So I think that's a good idea. That which point, suppose somebody is asking me, plantar is extensor only, nothing else. Suppose, difficult for me to explain. But I will say that the only extensor plantar indicates some pyramidal tract involvement. Although other manifestations are not there, I will keep in mind. And with the evolvement of the disease, I'll be able to explain the plantar extensor. And I think in the exam, if you give this explanation, it's a mark. And in the practice also it happens so. So I think this is really very good suggestion. I think in the future, even I would request the mentors that just you can draw the attention of the students. And if they still come with these preparations, definitely we are also learning. We can go for the innovation changes, and then it becomes a good presentation. Thank you very much, Yogesh, and your team. Thank you. Thanks a lot.
Thank you both the experts. Thank you, Baldev bhai, sir. Thank you,
ma'am.
sir. Yeah.
So thank you very much, sir, for best mentorship and moderation. And we welcome again Dr. Amit Rao Singh sir, and Dr. Praveen Kumar for the next upcoming session of the PG clinic in the future, near future. Next week, upcoming Saturday, we are going to discuss the muscular dystrophy, and one of our student, Dr. Anna from the Government Medical College Surat, will represent the case discussion. So be with us, and thank you, Dr. Mahima, for the best presentation and wonderful case discussion. Thank you very much, sir.
Thank you.
Thank you.
Thank you.
Thank you very